My name is Patrice O'Leary. I've been a physical therapist for over 20 years, primarily working in the inpatient rehab setting. Today, I'll be talking about a pattern we've all seen, the hand that won't open after a stroke. More specifically, persistent finger flexion that limits reach, grasp, and release. Today, I want to walk you through how I think about this clinically and one thing that I'd like to try in the clinic that I hope you will too. So this is the pattern that we often see post-stroke. The fingers are flexed, the thumb is in the palm, the wrist is flexed, and the forearm is pronated. This functionally presents as difficulty with reaching, grasping, and especially with releasing objects. This isn't just a problem with the hand though. It's reflecting what's happening throughout the entire system, the brain, the nervous system, and the sensory feedback loop that controls and interprets our movements. So before we try to open the hand, we need to first understand why the system is holding it there. So why does this happen? Hand flexion after neurologic injury is multifactorial. First, there's a loss of corticospinal control. This is when the brain loses its ability to selectively activate muscles, so flexor tone tends to dominate. Next, positioning and alignment play a big role. If the scapula isn't stable and the arm is internally rotated and pronated, the hand is already at a mechanical disadvantage. When consistently in this position, soft tissue shortening begins and tone reinforces that posture over time. Third, sensory and perceptual deficits. If the brain isn't getting input or awareness, it stops using the hand efficiently or effectively. This further drives disuse and abnormal positioning, the use it or lose it principle. So, if we can't fix the hand at the hand, where do we start? To begin, we need to prioritize the position of the trunk, scapula, shoulder, wrist, and forearm, since they directly influence what the fingers do. The system prioritizes stability over mobility, so the hand will stay closed as a protective strategy. Without giving the system a stable base, we can't expect the hand to open or function. So before we treat the hand, we need to first begin proximally, ensuring alignment of the trunk and the scapula. Next, sensory and perceptual input. This is how we start to build trust in the movement. The system, the brain, nervous system, and sensory feedback loop no longer has a reliable map of the arm. The nervous system needs feedback to understand where the limb is in space, so things like weight bearing, vibration, touch, and taping can help the system feel more stable and more confident in the position. This allows us to begin to elicit muscle activation for opening. Things like active assisted wrist and finger extension, closed chain strengthening, sustained weight bearing with fingers extended and wrist extended, and functional grasp release practice, to name a few. Finally is integration, where we are able to begin to use the arm to help with daily functional tasks, and most important, meaningful tasks for our patients. So the brain uses sensation to predict, organize, and execute movements. What does sensory input actually do? So first, it helps build the internal body map. It's helping your brain know where the limb is in space and how it is moving. Without it, we might see our patients misjudging position and having poor targeting. It guides movement planning. Before movement starts, the brain uses sensory input to predict how much force is needed, determine direction and timing, and select the right muscles. It enables feed-forward control. The brain anticipates movement based on prior sensory experiences. This helps us create smoother and more automatic movement. After a stroke, impaired prediction may appear as slow and effortful movements, as everything is becoming trial and error. It supports muscle sequencing. Sensory input helps coordinate timing and order of muscle activation, which is critical for functional tasks such as reach and grasp. Without it, co-contraction or abnormal synergy patterns may appear, and poor dissociation. where everything is moving together. It drives error detection and correction. It tells the brain either that worked or they need to adjust something. It allows for real-time corrections. Without it, our patients may have repetitive errors, increased reliance on vision, and limited motor learning. When sensory processing is impaired, patients will have difficulty initiating movements, sequencing, and present with inconsistent performance. Our patients may look like they know what they want to do, but can't do the task. Since sensory input drives motor output, one strategy I like to use is kinesio taping. Why is this a go-to intervention for me? Taping helps with alignment by bringing the wrist, fingers, forearm, elbow, and shoulder into a more functional position. It provides continuous somatosensory input, helping the system feel more stable and more aware of the limb, which directly impacts the sensory feedback loop needed for sensory processing, motor planning, and motor output. I will often use a combination of these taping methods on my hemiparetic patients. The first taping is to help prevent shoulder subluxation. Ensuring alignment of the shoulder is crucial. The second is for alignment of the wrist and hand. You can see the immediate change following taping from a spastic hemiupper extremity. The helix wrap helps with alignment of the entire chain, reduces flexor synergies, improves awareness of the entire arm, and will bias the arm towards supination if you wrap the helix laterally. Instead of fighting the hand, we're giving it a better starting point to participate in functional movements like supporting, reaching, and interacting with objects. This allows our therapeutic interventions to be more effective within sessions and outside of them. This taping isn't about fixing the hand, it's about changing the input the system is receiving in order to help organize movement. The taping, especially the helix pattern, offers continuous somatosensory input for days, which is, in my experience, has significantly expedited muscle activation, managed tone, increased positional awareness, and increased integration into function. On this slide, we show how to progress the hemiparetic upper extremity from basic activation to functional use. We always start with static weight bearing. This will provide stability, joint approximation, and sensory input to help the brain recognize the limb. From there, we can move to dynamic weight bearing, where the arm stays planted but the body moves. This challenges postural control and begins active engagement. Next is active assist. Here is where the patient begins to participate more. We guide movement, especially for wrist and finger extension, to build motor control. Next, we move to active use, where the patient is initiating movement with less assistance, working on reaching and simple grasp-release tasks. Finally, we move to integration into functional activities like stabilizing objects, assisting in daily tasks, which is the ultimate goal. If the patient is unsuccessful at any level, we don't need to push forward. It's a time when we can regress. Regression might mean adding more support, reducing the complexity of the task, or increasing sensory input and cueing. We may go back to focusing on proximal control, like trunk or scapular alignment, as that's the foundation for distal function. The key is meeting the patient where they are while still challenging the system enough to promote recovery and neuroplastic changes. Clinical takeaway. So the hand is not the problem. It's reflecting what's happening throughout the entire system. If we want the hand to open, we must address proximal stability, alignment, sensory input, and motor planning, because the hand doesn't open unless it trusts the position. If we provide the system a position it can trust, it will promote greater recovery and the ability to utilize the hemiupper extremity in everyday tasks. Thank you.